Hello, I'd like to thank your great leader, not mine, Alex Thomas, for coercing me, inviting me to be here to speak about my experience using cell therapies in the treatment of spinal pain. My name is John Knab, and I run an independent interventional pain management practice in Wilmington, North Carolina, where we have been fixing the mistakes of our surgical colleagues. I'm sorry, that's the wrong note again, where we have been collaborating with our surgical colleagues for over 23 years. I'm happy I won last night's debate, but I am not here to gloat. I am going to go over my approach to lumbar disc-related pain. I'll review what we used to do for discs and show you why some of the current solutions proposed by industry may not work. Most important, I want to convince you that we should be thinking of the disc as being a three-factor problem. One that is mechanical, chemical, and in some cases, bacterial. These are my disclosures. And here is the issue. In my world, when it comes to treatment of discogenic pain, and in particular, treatments that are covered by insurance, we are dead in the water. In fact, we're no better now than we were in 2001, 22 years ago. We actually have fewer options now than we did then. So some of us have been using PRP and stem cells, but what do we use and when, and how do we convince people like you that it even works? Even worse, we have patients flying all over the world getting $50,000 stem cell treatments and the FDA threatening to shut the whole field down. So this is actually true. We used to reuse and resharpen the spinal needles every night at my training hospital, Virginia Mason Medical Center. And my point is, like some of you, I'm talking to you, Van Huffman. I'm old. I've been around the block and I have seen a lot of stuff come and go. Some of the old stuff actually did work, but most things in medicine that are good eventually get labeled as being investigational, and then we can't use them anymore. And this is what happened to a lot of our options. So industry steps in to fill the vacuum, and we have things like stem cells in a vial, ground up disc, also in a vial that we can buy and inject into our patients. Or we can use autologous products, meaning point of care platelet, bone marrow, and fat preparations that can be processed in an FDA compliant manner to inject back into the patient during a same-day surgical procedure. Does PRP or stem cell therapy play a role in the treatment of discogenic pain? First, a brief history of how we got here. Here is IDET, or intradiscal electrothermal coagulation. Great concept invented by the Saul brothers, introduced in 1997. Just heat and treat. Problem was, it was only partially successful in about 30% of patients. And oh yeah, you can sometimes heat up the cauda equina. Notice those yellow things running back and forth in the back. I'm told that's not a good thing to heat up the cauda. So by 2005, 60,000 IDET procedures had been performed. And then a couple of papers came out saying it just didn't work that well. So it kind of disappeared. So for IDET, it was a fail. So nucleoplasty was pretty cool. This was approved in 2000. The anode cathode array at the tip of this device created a plasma field which vaporized a portion of the nucleus. Even though it probably didn't work for the reasons they thought it worked, it actually did work, especially for patients with a radicular component. But all of a sudden, this office-based 15-minute procedure also became investigational and non-covered. This is a close-up of the probe tip. They called it coblation. Cool. And so yet another fail. Here's a brilliant idea. Take Augmentin for 100 days. Fast forward to 2006, researchers are proposing the idea that most back pain can be cured with a 100-day course of good old Augmentin. What could go wrong? You and your antibiotic resistance, C. diff enterocolitis, quit worrying. Just take these pills. It's going to be okay. So was this the end of pain management and even spine surgery as we knew it? Maybe not. Among other reasons that taking Augmentin for a third of a year was a really bad idea, and also one that gave you terrible diarrhea, was the other problem of conflict of interest for one of the authors. While he was publishing and speaking on this miracle discovery, He was also setting up a business to train doctors how to be MAST certified at the reasonable fee of 200 British pounds per session. MAST standing for, I can't really see that, Miracle Antibiotic Scam Therapy, I think. And so, yet another fail. Okay, so what about injecting methylene blue into the disc? Makes sense, right? I don't know. I wouldn't have thought of it. But there are actually some anti-inflammatory and immune modulating effects of methylene blue. However, it seemed that the majority of the work on methylene blue was coming out of a particular group that may have been looking at the treatment as a one-size-fits-all panacea that could be given to the entire populace of a certain country, without naming names. Intradiscal methylene blue remains a controversial treatment option and is not FDA approved. Yes, you see the pattern here. Fail. What if we could take healthy disc material, send it to the lab, culture expand it, and put it back into a vial, and then inject that into unhealthy discs? Mesoblast, which was an Australian biotech firm, did just that. But it had trouble figuring out why the subjects getting the higher dosages of stem cells didn't do as well as those getting lower dosages. And they had trouble reproducing their results. So, like any early phase trial in a publicly traded company, when the data is not robust, Wall Street comes a-knocking. And as it stands now, Mesoblast stock is down over 80% from its peak and looks to be yet another fail. Okay, fast forward to 2020, the VAST trial results were published. This group used an off-the-shelf preparation of ground-up nucleus pulposus to inject into degenerated lumbar discs. So I heard about this. I started talking to some of the authors and sponsors of the study about 2 years, and I still couldn't get an answer about what exactly was in the drug and why injecting allogeneic nucleus pulposus into damaged discs would be a smart thing to do in the first place. I mean, that's all the stuff that aggravates nerves when it leaks out, right? Thromboxane A2, tumor necrosis factor, all the bad interleukins, 1, 16, 17. And I also wondered why the patients in their phase 2 trials receiving placebo, which was saline, seemed to do just as well as the patients receiving active drug. I still don't know what's in this proprietary drug. Now they're saying it also has some end plates in there as well. I don't know whether it's a 351 or a 361 product, but I do know it's about $9,000 per vial, and you have to inject it in a surgery center or hospital. So you can do the math for the cost of this therapy, about quadruple that 9,000. So saline is a lot cheaper and appears to work just as well. So non-inferiority to saline, not a big selling point in my book. So that's it. Those are all the options my industry has thought of. Then this, not from industry, just from an orthopedic surgeon in Colorado, comes out in 2017, bone marrow concentrate, better known as stem cells, injected into discs. Patine's group studied 26 patients over 3 years and found that in patients receiving more than 2,000 colony-forming units per cc of bone marrow concentrate, there were no adverse events, and patients' VAS scores were reduced by 75%. Both ODI and VAS improved in patients receiving the 2,000 CFUF target dose, and the authors proposed that bone marrow stem cells might be providing natural healing mechanisms to the avascular disc tissue. And they also proposed that bone marrow concentrate might have an anti-inflammatory mechanism of action, which might lead to improved cell repair and tissue regrowth. Other authors proposed that in addition to its anti-inflammatory effects, bone marrow concentrate might have antibacterial properties to it. So 80% of patients in this study were able to avoid surgery during the 3-year study period. Looks pretty good, right? Well, not always. This is what can happen and did happen, and still does happen to some patients getting intradiscal bone marrow concentrate. BMC does not appear to be a foolproof antibiotic. In fact, this happened to us twice, 2 cases of discitis, one for my partner and then one for me. Our only cases of discitis in a combined 46 years of practice. And in private practice, one disc infection is one too many. So we stopped doing intradiscal bone marrow concentrate. We just stopped. After a great start, we were once again dead in the water. So our solution was to approach patients from a functional spinal unit standpoint, basically injecting everything but the disc. That's the facet joints, epidural space, iliolumbar ligaments, sacrotuberous ligaments, interspinous and supraspinous ligaments, SI joints, paravertebral muscles, everything but the disc. It works really well, but it does not address the disc. We stay outside the disc. So could intradiscal PRP be an option for the disc component? If we were going to use intradiscal PRP, what type, what dose, and what's the rationale for using PRP in the disc? Could PRP help us to treat all three aspects of disc pathology, including mechanical, chemical, and infectious? What this picture doesn't show are the inflammatory changes that can happen when the injured disc gets colonized with bacteria. It also does not show modic changes, which are commonly seen adjacent to damaged discs. Why do modic changes happen, and why do discs become inflamed? You guys remember that 100 days of Augmentin? Well, these guys were not all wrong. One of the proposed theories regarding the development of modic change includes the idea that when a disc is injured, the gram-positive rod-shaped anaerobic C. acnes, formerly known as P. acnes, travels from the bloodstream into the damaged disc and then into the end plate, where it causes an inflammatory reaction. This is just one of the many studies looking at the role of Cutibacterium acnes in chronic low back pain. This group looked at a total of 256 samples, 53 discs from 23 patients who were undergoing surgery anyway, and they found a C. acnes prevalence of 34.8%. That's 35% of the patients getting their discs taken out were positive for C. acnes. And even more interesting, they found that patients who were positive for C. acnes at the time of surgery were 4 times more likely than patients who were negative for C. acnes to have neuropathic pain at 6 months following surgery. So stop here for a second. Even if you've fallen asleep by now, take a quick look at this graph. Why wouldn't you want to try to kill these bacteria at the time of surgery? Why are we not doing this? How could you do this? Well, maybe you could do that with PRP. What kind of PRP might be able to kill bacteria? Maybe leukocyte-rich PRP with a lot of granulocytes in it. So when we prepare PRP in our office, depending on how we spin it and process it, we can make amber PRP, which we call leukocyte-poor PRP, or red PRP, which we call leukocyte-rich PRP. For some clinical conditions, that higher dosage of granulocytes may be a desirable attribute. Greg Lutz's group looked at this very question and showed that leukocyte-rich PRP with high granulocyte counts were very effective at reducing C. acnes at 48 hours. Higher granulocyte and monocyte counts were clearly correlated with a log 10 reduction in C. acnes. Back in the day, when we used to do discogram for you guys, we would always use cefazolin, 100 micrograms per cc in our contrast. Turns out Kefsol is not a very good drug in terms of killing C. acnes. How about gentamicin? How bad is gentamicin if you're C. acnes? Well, if you're C. acnes and you're exposed to gentamicin at a concentration of 500 micrograms per cc, there is a 99.9999% chance you'll be dead at 48 hours. This graph shows a 6 log kill rate at 48 hours for C. acnes exposed to gentamicin, 500 mics per cc. Easy way to remember that the log kill rate is just the number of nines you use. In this case, it's 6 nines, so that's 99.9999% effective at killing C. acnes. So now we may be on to something. We've got both leukocyte-rich PRP and gentamicin killing bacteria, which remember are present in up to 35% of patients. And we've also got high levels of growth factors in PRP that may be helping to slow down or even potentially reverse disc degeneration. But does it work? These are images of my accountant suffering from multi-level degenerative disc disease, 3-level modic type 1 change, and severe stenosis at L1-2. He was pretty miserable, and all of my surgical colleagues who are babies were too afraid to touch him, so we injected leukocyte-rich PRP into his intervertebral discs at L1-2 and L2-3, along with that voodoo doll FSU, functional spinal unit technique I showed you earlier. This is his MRI at 3 months after the procedure. This bulge is gone. Radiology report reads prior severe stenosis at L12 has resolved. And the patient was reporting overall pain reduction of 80% and a significant reduction in ODI. He was back to golfing, traveling, and accounting, and I haven't seen him in 10 months. And believe me, I'm going to hear from this guy the minute he starts hurting. So he's doing well. This is another patient of mine, 44-year-old female with chronic axial low back pain due to high intensity zone annular tear at L5S1. It's been present for years, along with severe axial low back pain. She was extremely anxious about having her disc injected, mostly because of the fear of infection that I personally implanted into her brain. And to make things even more interesting, I couldn't use contrast, so I really couldn't see where the PRP was going. These are images from just prior to the procedure, showing the high intensity zone persistent over a number of years. And we injected her in February of this year. This is the high intensity zone appearance at 6 weeks following intradiscal PRP. The images are from a pelvic MRI, which I ordered for different reasons, but I asked them to get sagittal and axial cuts of the bottom two discs, which we see here in the T2 images. This is a tear that has been present for years, now gone at 6 weeks after her PRP inject. These are some images from Greg Lutz's recent book, also showing similar improvement in appearance of HIZ at 3 months following intradiscal PRP. But how about my colleagues who are still promoting the idea that stem cells just work better than PRP? Is this true? Maybe not. If you look at the data from Anu Navani's group, who have submitted this placebo-controlled head-to-head comparison in 57 patients receiving intradiscal PRP versus BMC. The outcome at 12 months were identical. There was no difference between PRP and BMC. And in terms of which is safer, PRP or BMC, I think you already know my opinion on that. How long does the effect last with PRP? This graph is from a survey of 29 patients who previously received intradiscal leukocyte-rich PRP. These patients were followed for up to 9 years and were still reporting durable, meaningful results in terms of both VAS and SF36. These patients have essentially been cured. And Lutz's most recent work suggests that by using even higher dosages of leukocyte-rich PRP, that's with PRP having platelet concentrations of 10 times or more over baseline platelet counts, along with specialized delivery devices, that some patients may need just a single treatment in order to achieve complete and permanent resolution of their symptoms. Quick anecdote, March 2021. It's the middle of the pandemic. We're invited to a friend's wedding, which you can't have because pandemic. So he creates a wedding venue in the middle of a field in Burgaw, farmland, 10,000 square foot tent, disco, entire fairground with a Ferris wheel there in the middle of Burgaw, carnival games, funnel cakes, you name it, it was all there. And a deluxe heated porta potty, which has a huge line of women waiting to get in it. So I'm in line and standing there with a young man. I say, I'm heading to the woods. He joins me and we give quick intros as we head out into the darkness. I say, what do you do? And he says, I'm going into the Coast Guard and I'm going to be a lawyer. I was going to go into the Navy, but I have a back problem, so the Coast Guard it is. I said, back pain, you say, back pain. And he said, yeah, actually, I had stem cells injected into my back 10 years ago. Really? I say, where? In Wilmington, he says. Wow, where in Wilmington? I asked. I can't remember. I think behind the Pizza Hut in Hampton Inn, he says. That was me, I said. No, I don't think so. Well, anyway, how you doing? He says, great, no problems at all. I'm cured. And, you know, I really think it was me that treated him. But a couple other clues. I checked my EMR. Sure enough, it was him and it was me. And it wasn't 10 years ago, it was 6. And it wasn't stem cells, it was intradiscal leukocyte-rich PRP. 40 minutes later, he comes up to my table and says, I called my mom, it was you. So we follow the results of our procedures, not by just tracking people down and going into the woods to urinate. We use Orthobiologics as our current registry. which is our third registry in 7 years. They've been fantastic to work with. These are data from my patients receiving intradiscal PRP with 12-month outcomes in NRS shown here. So does the PRP is as good as BMC theory holding up for us with real world data? Apparently it is, as you can see here, with PRP and BMC having similar ODI outcomes out to 18 months. And it's never bad to have a little friendly competition, just like last night when I won that debate. Here is me kicking my spinal interventionalist colleagues' butts in terms of ODI for spinal pain at 18 months. Boom. So, discogenic pain has 3 components to it. Earlier technologies failed because they were taking care of one or at most 2 elements. I hope that even if you're not convinced that PRP can help your patients, you're convinced that there's something going on with that C. acnes. And with that, I hope you'll also agree that injecting gentamicin into the disc, maybe even at the time of surgery, might be a good idea. I'm convinced that with the combination of intradiscal gentamicin and high-dose leukocyte-rich PRP, I have something that allows me to help my patients with minimal concern for discitis, all without burning any bridges along the way. I thank you for your attention, and I will be happy to talk to any of you after my talk. Thank you.